Question 1. A 32-year-old woman with a history of systemic lupus erythematosus presents with chest pain. EKG shows sinus tachycardia. Which of the following is the most likely cause? Coronary artery atherosclerosis. B. Coronary artery vasculitis. C. Pericarditis. D. Myocarditis. E. Endocarditis. C. Pericarditis. Summary. Pericarditis is the most common cardiac complication of SLE. While not usually serious by itself, associated pericardial effusions can potentially cause hemodynamic compromise. Chest pain is the most common symptom of pericarditis in SLE patients. Myocarditis also commonly occurs in patients with SLE, but it is often clinically silent and overt symptoms are more likely to be related to signs of CHF such as shortness of breath or peripheral edema. Coronary artery disease can complicate SLE as well but is less common than either pericarditis or myocarditis. Non-infective endocarditis, also known as Libman-Sachs endocarditis, is present in a minority of patients with SLE. Lesions can get superinfected and cause valvular insufficiency, often without frank chest pain. The most common overall cause of chest pain in patients with SLE is likely musculoskeletal disease. Question 2. Which of the following arteries supplies the atrioventricular AV node in most people? Left coronary artery. B. Right coronary artery. C. Left anterior descending artery. D. Left circumflex artery. E. Right posterior descending artery. B. Right coronary artery. Summary. The right coronary artery supplies the AV node in greater than 80% of patients, and the left circumflex artery supplies the AV node in the rest. Question 3. Which of the following is the most common initial dysrhythmia in symptomatic patients with Wolff-Parkinson-White syndrome? Multifocal atrial tachycardia. B. Atrioventricular nodal reentrant tachycardia. C. Mobitz type 1 second-degree AV block. D. Mobitz type 2 second-degree AV block. E. Torsade D points. B. Atrioventricular AV nodal reentrant tachycardia. Summary. Wolff-Parkinson-White syndrome is the most frequently occurring accessory pathway syndrome. Patients have an accessory conductive pathway from the atria to the ventricles that pre-excites the ventricular myocytes before the AV node releases the normal sinoatrial depolarization. As a result, patients with WPW often have a shortened PR interval and a delayed QRS upstroke, called the delta wave. The accessory pathway can cause reentrant dysrhythmias, of which atrioventricular nodal reentry is the most common. In reentrant dysrhythmias, the accessory pathway can conduct retrograde, where the AV node conducts in the normal direction, producing a narrow QRS complex and an orthodromic pattern, or anterograde, where the AV node conducts backwards, producing a wide QRS complex and an antidromic pattern. MAT is seen in the setting of chronic pulmonary disease and is not usually seen with WPW syndrome. AV blocks and torsade D points are not commonly seen in WPW syndrome. Question 4. Which of the following is the most appropriate initial antihypertensive medication for hypertensive crisis in pregnant patients? Nitroprazide. B. Nitroglycerin. C. Clonidine. D. Libtalol. E. Hydrochlorothiazide. D. Libtalol. Summary. Intravenous medications are most appropriate for rapid control of BP. Libtalol is safe and effective during pregnancy and produces predictable control of BP during hypertensive crisis such as eclampsia. Hydralazine is an antihypertensive medicine that is also commonly used. Nitroprusside also provides excellent BP control but has not been proven safe during pregnancy. Nitroglycerin causes preload reduction but has little effect on afterload reduction, which is the more important intended mechanism of action for antihypertensive agents during crisis. Clonidine and hydrochlorothiazide are oral medications that have a limited role in acute management of BP during hypertensive crisis due to unreliable absorption and efficacy. Question 5. Which of the following is the most common complication of mitral stenosis? Atrial fibrillation. B. Endocarditis. C. Congestive heart failure. D. MI. E. Pneumonia. A. Atrial fibrillation. Summary. The most common complication of MS is atrial fibrillation, which puts the patient at high risk for thrombus formation and embolism. Atrial fibrillation occurs due to the severe atrial hypertrophy that results from the stenosed mitral valve preventing flow into the left ventricle. Question 6. Which of the following is true regarding reciprocal ST depressions seen in acute MI? They have little prognostic significance. B. They are more commonly seen in inferior MI than anterior MI. C. They have poor specificity for acute MI. D. They are more commonly seen in acute pericarditis than acute MI. E. They are usually upsloping when seen in the setting of acute MI. B. They are more commonly seen in inferior MI than anterior MI. Summary. Reciprocal ST depressions associated with ST elevations have high specificity for acute MI, reported to be greater than 90%, and are not usually present in non-ischemic conditions. Their presence confers a higher risk of poor outcomes. Reciprocal ST depressions are usually downsloping. Most inferior wall MI exhibit reciprocal ST depressions, whereas most anterior wall MI do not. Question 7. Which of the following findings is present in most patients with endocarditis? Signs of embolic stroke. B. Painful subcutaneous nodules on finger pads. C. Heart murmur. D. Splenomegaly. E. Petechiae. C. Heart murmur. Summary. Audible heart murmur or fever is present in almost 90% of patients with endocarditis. Murmurs are less common and fever is more common in IV drug users. Choices A, B, D, and E occur in less than half the number of patients with endocarditis. Some type of vasculitic skin lesion will occur in most patients, but a specific type such as ossular nodes, Janeway lesions, petechiae, or splinter hemorrhages each occur in less than 1/4 of patients. Splenomegaly is present in roughly 1/3. Question 8. A 65-year-old woman presents with lightheadedness. She denies chest pain or shortness of breath. Vital signs are 99.0 degrees Fahrenheit, 160, 20, 144 by 75, 96% RA. The EKG is shown. Which of the following is the most appropriate next step in management? Adenosine. B. Diltiazem. C. Amiodarone. D. Cardioversion at 50 joules. E. Cardioversion at 200 joules. C. Amiodarone. Summary. The EKG shows a wide complex, regular tachycardia, which is almost always ventricular tachycardia. Amiodarone, procainamide, or lidocaine may be used to treat stable VT. Although cardioversion may also be performed, it is painful for awake patients and may not be necessary for patients without hemodynamic instability. Adenosine and diltiazem are both used in patients with narrow-complex tachycardias and have no role in ventricular dysrhythmias. SVT with aberrant conduction can also cause a regular, wide-complex tachycardia. VT is far more common and may be distinguished from SVT with aberrancy by the presence of fusion beats, atrioventricular dissociation, wider QRS complexes, 0.14 second, and concordance of precordial leads. When in doubt, the emergency physician should always treat regular wide complex tachycardia as VT. Question 9. A 44-year-old man is brought to the ED in cardiac arrest due to ventricular fibrillation. He responds to a defibrillation attempt with return of spontaneous circulation, but he is still comatose. You control his airway with endotracheal intubation. You decide to initiate therapeutic hypothermia. Which of the following is thought to be a beneficial mechanism in therapeutic hypothermia? Reduction in post-arrest infection. B. Reduction in cerebral oxygen consumption. C. Reduction in pH. D. Increase in cerebral glutamate levels. E. Increase in superoxide levels. B. Reduction in cerebral oxygen consumption. Summary. Therapeutic hypothermia is thought to have several beneficial actions, including times reduction in cerebral and myocardial oxygen consumption, times reduction in acidosis, times reduction in excitatory neurotransmitter levels, such as glutamate, times reduction in free radical formation. Certain factors are either unaffected or made slightly worse with therapeutic hypothermia, such as infection and coagulopathy. Therapeutic hypothermia has been shown to be beneficial in cases of cardiac arrest from ventricular fibrillation and pulseless ventricular tachycardia. Cardiac arrests due to asystole and pulseless electrical activity have not shown the same degree of outcome improvement, and use of therapeutic hypothermia in these scenarios should be performed on a case-by-case basis. Question 10. A 57-year-old woman with hypertension who has not seen a doctor in 30 years presents with weakness and fatigue. The EKG is shown. After appropriate further evaluation, which of the following is most likely the appropriate next step in management? Defibrillation at 200 joules. B. Cardioversion at 50 joules. C. Lidocaine 150 mg IV. D. Calcium gluconate 100 mg per kilogram IV. E. No acute management. Follow up with primary care. D. Calcium gluconate 100 mg per kilogram IV. Summary. The EKG demonstrates diffuse tall T waves consistent with hyperkalemia. The history of absence of medical care, untreated hypertension, weakness, and fatigue suggests the possibility of renal failure as the underlying cause of hyperkalemia. Potassium levels should obviously be confirmed on laboratory tests, but cardioprotective agents such as calcium chloride or calcium gluconate should be ordered early. Defibrillation should never be performed in awake patients. Cardioversion should only be performed with a clear history of hemodynamic instability. Lidocaine is used for wide complex tachycardias, but has generally been supplanted by amiodarone for acute use. Question 11. Which of the following cardiac findings is expected in hypothermic patients? QT interval prolongation. B. Sinus bradycardia. C. Atrial fibrillation. D. J waves. E. All of the above. E. All of the above. Summary. Though a transient tachycardia may occur, sinus bradycardia develops and the heart progressively slows as the body cools. In fact, the finding of a relative tachycardia in a hypothermic patient should trigger a search for a cause. The PR, QRS, and QT intervals may all become prolonged, although this finding is most common in the QT segment and also correlates with the degree of hypothermia. J waves, or Osborne waves, are the most discussed EKG feature in hypothermia. They are additional waves at the junction of the QRS complex and the ST segment and tend to be upright in AVL, AVF, and the lateral precordial leads. Any atrial or ventricular dysrhythmia may occur, but atrial fibrillation is the most common and it usually spontaneously converts to sinus rhythm upon rewarming.